We have our my good friend Dr. Vineet Ratra from Shankar Netralaya. He is in Chennai now. He's going to talk to us on glaucoma following VR surgery. Over to you, Vineet.
Thank you, Satyan, for that.
His wife is a VR surgeon.
Yes. So I get a lot of VR glaucomas, but mine's not a vast. So mine's more a secondary glaucoma. So first I must give our salutations to Dr. Badrinath, whom we lost sadly a few months back. Well, I have no financial disclosures with respect to this presentation. So mine's more a talk on secondary glaucomas than vast. And well, our eyes that require, require VR surgery more prone to glaucomatous damage, or eyes with POAG actually having higher rate of retinal detachment. Well, the common factor here is myopia. And what's important here is that it's a diagnosis which is more based on clinical features. You need to look at the IOP, you need to look at the gonioscopy, you need to look at the optic nerve head, and well, you also need to look at the retina. There are various risk factors for the raised intraocular pressure, that is the proliferative vitreoretinopathy, a patient who's had a pars plana vitrectomy with scleral buckle, and also probably a lensectomy. There are various VR procedures which are responsible for the raised intraocular pressures. I'll deal with a few of them. So first is the silicone oil. The intraocular pressure rise can be any time and of any degree. It could be up to, if you keep the oil, up to even 56% at 8 months. And the risk factors for the raised intraocular pressures are more a pre-existing glaucoma, diabetes, and aphakia. The glaucoma could be closed angle when you have a pupillary block, or an open angle inflammation in the early postoperative period, or later where you have infiltration with silicone oil bubbles, or an emulsified oil in the anterior chamber. So how do you manage these patients? Well, medical therapy in the early postoperative period. If there is inflammation, you can increase the steroids. If otherwise, use aqueous suppressants and prostaglandin analogs along with it, and most of the time you could actually control the intraocular pressure. Well, in patients like this, where you can see that there is oil in the anterior chamber, it's not come very clear there, but you can see there's oil in the anterior chamber and in the subconjunctival space, you can end up with a pupillary block, in which case you would need to do a laser iridotomy to the if you have had a light oil, generally a PI would be done inferiorly. If you have heavy oil, it's done superiorly. You can do a YAG to open it. And if there is a fibrin, blood, or retroiridial membrane, you can try TPA. When you have patients like this, you need to remove the oil. Longer the oil is in the eye, higher is your risk of emulsification. So in patients where the oil removal needs to be done, in the early stages, if there is, you always have to weigh the risk with the recurrent RD, and you can do a trabeculectomy with mitomycin C or a GDD. We have seen fantastic videos on how to go about it. But we do need to remember that in these patients, you can have conjunctival scarring. Over here, you have oil which has seeped down inferiorly. And in these patients, you would need to think of a cyclodestructive procedure. So you can, if the risk of redetachment is high, we need to think of a transscleral cyclophotocoagulation. But if your retinal surgeon is willing to go ahead with the silicone oil removal, you can advise them to do an endocyclophotocoagulation, limited though. So the second is with intravitreal gas. The rise in intraocular pressure is more with C3F8 than with SF6. This is because it has higher expansion, volume expansion, and also increased longevity in the eye. So the risk factor is the higher concentration. the older patient. And in these patients, it's important to remember that you don't check the pressures with a pneumatic because that underestimates the intraocular pressure, but you would rather want to use applanation and or Perkins. You want to tell them to avoid air travel because you can have a expansion because of change in atmospheric pressure, or use nitrous oxide where this gas can get absorbed along with the intraocular gas and cause a rise in pressure. The cause of intraocular pressure is open angle, where the gas expansion exceeds the rate of outflow. The increased volume causes the posterior chamber pressure to build up without angle closure. But at times you can have an anterior displacement of the lens iris diaphragm along with ciliary body edema, which can cause an angle closure. So what's important here is to position the patients prone, give aqueous suppressants like oral oral carbonic anhydrase inhibitors. The pressure is too high, tap the gas. If there is a pupillary block, do a peripheral iridotomy. And in some cases, yes, you would need to think of doing a trabeculectomy or an AMD or a GDD device. Well, in patients with scleral buckle, we do know that shallowing of the anterior chamber does occur in patients with following scleral buckle without angle closure. This could be in about 50% of the patients, but you can also end up with an angle closure glaucoma in up to 4% of these patients. So, well, why does this occur? There is a shallow detachment of the ciliary body. This causes an anterior displacement of the ciliary body and angle closure. But if you have a very high, deep buccal effect, this can cause a compression of the vortex veins, choroidal congestion, engorgement of the ciliary body, and anterior shift of the lens iris diaphragm, and this can lead to angle closure. So in patients like this, you would need to be careful. If there is anterior segment ischemia, you need to cut the band. Most of the angle closures after scleral buckle do resolve spontaneously in a few days or weeks. You need to give them cycloplegic steroids and aqueous suppressants. Myotics are, you need to avoid them because there is no pupillary block, there is no role for a laser PI, but you can think of doing a laser iridoplasty to open up an angle if the angle is too shallow. So in these patients where you can have an anterior migration, you can have scarring. In these patients doing trabeculectomy, so I'll have to take a minute more. So surgery is difficult. So doing trabeculectomy in these patients is difficult. If there is a very high buccal effect, you can cut the encircling band. You can put a tube with the plate beyond the buccal which is there, or do cyclodestructive procedures. Well, in patients following anti-VEGF, well, this is something which is now we are seeing more and more often. It depends on the number of injections and the frequency of injections that the patients get. Most of these are aging populations, and most have vascular, like either a diabetic or a vein occlusion. Yes, CNVM is a cause of it in some of them. So the acute rise in pressure is what generally occurs. So this can be avoided by having a subconjunctival reflex. Sometimes you can do a paracentesis. This is more common in patients with who have a glaucoma or a small eye. There is a controversial role of giving medical prophylaxis like Diamox preoperatively. Paracentesis has its risk, and one could decompress the ocular or do an ocular decompression using a conjunctival swab. There are different studies which have shown that there is an increase in intraocular pressure by the total number of, based both on the total number of injections and the frequency. It's more in the groups where, depending on the type of anti-VEGF that you get, with the newer anti-VEGFs like Eylea, your size of the molecule is smaller. So why do these cause raised intraocular pressure? One is because of the obstruction of the trabecular meshwork, because of these molecules. The second is a direct effect of on the trabecular meshwork. It slows the metabolism and replication. It also causes trabeculitis. And it has also shown that the Schlem's canal can collapse, thus reducing the endothelial cell because of the reduced endothelial cell permeability and smooth muscle contractility. Well, for the paucity of time, we do
I think
need
we
to...
can skip that.
Yes, sir.
Yeah. Thank you very much.